Alrighty, it's 1 o'clock, so we're going to go ahead and get started. Hello, everyone, and welcome to another CFHA webinar. This is our last CFHA webinar of 2019, but it's also the last CFHA webinar of the decade, which is kind of fun to think about. But my name is Liana Edwards. I'm the CFHA Administrative Assistant, filling in for Natalia Serrana, who's our CEO and couldn't be on the call today. But nonetheless, we have a great presentation for you all. Dr. Julie Glass is a clinical research psychologist at the VA for Integrated Healthcare in Buffalo, New York. She completed her graduate training at the University of Buffalo and had a concentration in addictive disorders, measurement, and treating tobacco use. In her role at the Center for Integrated Healthcare, she's focusing on developing primary care team-based interventions for unmotivated smokers and drinkers with comorbid health conditions. She's interested in team-based care, multimorbidity, use of technology in healthcare, and behavioral health interventions in integrated primary care settings. She's a recipient of the VA 5-year Career Development Award and RAC's 2019-2020 Research Fellow. So without further ado, I hand it off to you, Julie.
All right, thank you, Leanna. So thank you for that really nice introduction. As Leanna said, I'm talking to you guys today about a presentation that I did at the CFHA conference that we thought would be helpful to give out to everyone in CFHA who might have not been able to attend that session or attend the conference. So I'll be talking today about how to select and use validated assessment tools in integrated primary care research evaluation and clinical care. And I will be showing you guys and walking you through the measurement selection tool that myself and Jen Funderburk put together. You should have received that recently today in your email. If you haven't, I'm going to be showing you guys different components of the measure in this presentation, and I can certainly send it to you afterward. But I wanted to just kind of start by saying I'm presenting today, but this work was really supported by a lot of people, including my co-authors on the presentation, Robin Shepherdson, Jen Funderburk, Emily Johnson, and Travis Lochran. So I wanted to make sure I gave them some props. Also wanted to just quickly note that I don't have any relevant financial relationships to disclose. And as a government employee, I also wanted to note that the views in this presentation are my own and do not reflect the views of the Department of Veterans Affairs or other governmental agencies. So I wanted to continue to make a couple acknowledgments here and also acknowledge my research staff here at the VA Center for Integrated Healthcare. We have a really excellent team of research assistants and grad students and prac students and undergrads. And I also just wanted to share with you guys, the audience here, if you didn't know about my center, it's the VA Center for Integrated Healthcare. And that's our mission statement, but we do a lot of really cool work. And so if you want to check us out, there is a link there in the slides. So what we're actually going to be talking about today is a couple of different things. I'm going to describe the importance of using validated evidence-based assessments in research and program evaluation and really try to make a case for using validated measurements and evaluating the validity of measurements before just using any old thing in our research and evaluation. I'm going to talk about some key indicators of psychometric validation and how to find those indicators and how to evaluate them and how to kind of weigh them against each other. I'm also going to give some tips and tools on how to identify and locate appropriate outcome measures to use, so where you can actually physically find them and how to obtain them. And then kind of throughout the presentation, as I mentioned, we have this decision-making tool. I'm going to walk you guys through how I use it and how you can use it for your own practice. So if you haven't already, I would recommend checking in your email for that decision tool and downloading it so you can kind of follow along as I'm presenting these slides. So I also wanted to, let me just mention, thank you guys all for coming. I know we're coming up on holiday season here, and I really appreciate having people listening to this webinar and who are interested in this really important topic. So thank you so much. All right. So the background of this, if you're here in this webinar, you may not need this background. You might have already been sold the idea that validated assessments are important. But I wanted to quickly make that case a little bit. So they're really vital. It's vital to use evidence-based and empirically based assessments. So some of the reasons for that are these are the tools that wind up driving policy changes and wind up becoming published works of research. And it could be things that wind up guiding diagnosis and treatment decisions. And if we're using tools that aren't validated or maybe aren't the most reliable tools, then all those conclusions that we're drawing or those decisions that we're making may be being made in error. Despite this, so we know that using validated assessments and measurements is important, but despite this, we know that there's a really big diversity in how measures are used and the extent to which different people are using validated measurements. A lot of times, people use, instead of a validated measurement, a homegrown measure. So what I mean by that is essentially, a person, a clinician or a researcher or evaluator wants to ask a question, wants to evaluate a particular symptom in a patient population, and rather than looking and trying to find a measure that's already been developed for that particular question, decides to write their own questions. So the question that might be popping into your head is, well, what's wrong with doing that? What's wrong with homegrown measures? I want to start by saying right off the bat, there's nothing inherently wrong with them. They might actually be really good measurements. But the problem with them is we simply can't know that because the opportunity for measurement problems with a homegrown measure is much higher. The reason being is that they haven't been rigorously evaluated the same way that a empirically validated measurement tool has. So validated measurements have gone through testing to basically prove that they're valid or reliable for use for a certain issue or for a certain population. So they've gone through that kind of vetting process, whereas a homegrown measure, even though it might look really good on the outside, has not gone through that vetting process. So we can't know for sure if it's really measuring what we want it to measure. The other thing is for a lot of validated measurements that exist right now, they have, they at one point were developed and they were a homegrown measure themselves at some point, right? But through the validation process, any problematic items or questions were looked at and identified and thrown out. So you're really getting the best version of the assessment, whereas on a homegrown measure that you might develop yourself, some of your items might be really good, but some of them may be not quite as good, and you won't know which ones are which without doing validation. So things that might seem like good items at first might actually not wind up being good validated items. So for example, let's say you were trying to measure readiness to change smoking behavior, and you write these 3 items here. So quitting smoking would be really important for my health. I can see why I should quit smoking, and quitting smoking has many benefits to my health. Those all might seem like really good questions, but if you look more closely, none of them are actually measuring readiness to change. They're measuring sort of health beliefs around the importance of quitting smoking, but not an individual's personal readiness to change. And so someone might not realize that when they're writing a homegrown measure, that the measure itself is actually not measuring what it's intended to. Another point with homegrown measures is it will be sometimes more difficult to generalize them. And it can be difficult when you're going to publish the results of your research or evaluation or even a case study. It might be difficult to publish your results of those things later on when you don't use a validated measurement. So I have a couple other examples of some items that have some problems to them. I'm going to read out the item and then talk through what some of the issues with that item are. So think about it when I read the item, what you think the problem is. So the first one, so for example, let's say you wanted to measure how many cigarettes a person smoked last week. So you design the question. It says, last week on each day I smoked blank, and then they enter the quantity. So I see a couple issues with this question. The first is you don't know what the quantity or it's not specifying what the quantity is. Right? So the person might write down cigarettes that they smoked each day, or they might write down how many packs they smoked, right? So you're not specifying the quantity, so you might not get the quantity that you were looking for. Another example of an issue with an item is, let's say you want to measure how satisfied a person is with their last behavioral health consultant's appointment. So you ask them the question and you have them rate on, a Likert type scale. The BHC was very helpful in explaining my condition and in providing me quick tools to help. Those are both really important things to measure, of course. But the problem with this item is it's asking both of them in a single item, right? So, the person rating it might not know how or, if they should consider both parts of that question when making their rating. So what if their BHC was really helpful in explaining the condition, but they didn't provide any quick tools, right? What's the person to do? How are they supposed to rate that? A third example, let's say you want to measure the feasibility of a new team-based intervention that you're developing for primary care. So you design a questionnaire. One of the questions is, I would really like to engage in this type of intervention. Again, probably a helpful piece of information to know, but that's not really a feasibility question. That's actually a question about a person's kind of personal idea around engagement. And finally, you're trying to measure a person's mood fluctuations in response to a new medication. So you have them rate the question, I'm feeling down and depressed. This might be a good item, but without things like a time frame. So I'm down and depressed for the last 2 weeks, for example, versus for the last 2 years. You might not be able to really use this question without additional information. So these are just a few quick examples of some of the issues that can happen when you're writing items, and without really spending a lot of time on considering those, people fall into this trap often of writing items that aren't validated and having their results being a little bit skewed because of that. So for that reason, again, we recommend, when possible, to try and use validated assessment tools rather than homegrown measures when you can. So this page just shows a couple of published articles by really good researchers and evaluators in Family Systems and Health, which is obviously a really good journal. So I don't mean to throw anyone under the bus, but all of these articles did wind up using did wind up using homegrown measures when there were validated assessment tools available. There might be reasons for doing that in some cases, but it's just an example that this can sometimes lead to homegrown measures being used with some more prevalence. So hopefully I've made the case. You want to try and find a validated measurement tool when possible. So you've made that decision, but the next step is to figure out what you're really trying to measure. So what do you want to measure? This is step one. So if you guys have the decision tool in front of you, you'll be able to sort of follow along. So this is your first step, figuring out what you're trying to measure. And you'll know this based on what your questions are, what your clinical population is. You want to consider questions around, are you trying to measure functioning? Are you trying to measure symptoms, affect, satisfaction, etc.? Basically, what's the goal of the measurement that you're doing? For people who are clinicians, a lot of times that's symptom and function ratings over time. For people in evaluation settings, it might be that, could be other things as well. And for people doing research, all kinds of different options. But you want to figure out what you're trying to measure. And you want to make sure that the measurement that you're choosing actually fits what you're trying to measure, because sometimes they don't always match up. So for example, I had a colleague who was hoping to evaluate in a patient population continuity of care surrounding cardiovascular conditions. And they found something called the Heart Continuity of Care Questionnaire, just 33 items long. Here's an example of some of the items. So some of the items were things like, I feel I was provided with all of the information I needed to know about my condition. My healthcare providers communicated well with me. I was given consistent information about the symptoms that should lead to me seeking help from my healthcare providers. So while these are all really potentially interesting and informative questions that could be helpful to know, as it turns out, those don't necessarily all reflect back on the main construct my colleague was trying to measure, which was continuity of care specifically. So even though it's called continuity of care, some of the items are hitting some different concepts around communication and knowledge. So you want to make sure that the measure you select is measuring what you're actually trying to measure. So I'm not going to click on this link because I want to keep my PowerPoint presentation up and I don't want to interrupt that stream, but I was going to link here just to the decision-making selection tool that was provided to you guys. So I'm going to kind of talk you through and orient you to that tool. Again, if you don't have it in front of you, that's okay. I'm going to walk through each of the steps here. But the first step in the tool is to do exactly what I was just saying, which is to identify what you're trying to assess. So ask yourself these types of questions. Are you trying to measure a symptom, a function, something else? What's the purpose of your assessment? Is this for clinical reasons? Are you tracking an individual patient, or are you trying to see the effect in your clinic of a new training that all of the clinicians went through? Or are you planning to use your results in a research application? You also want to consider if you're trying to, or if you're planning to publish your findings in a journal later on. These are things that can affect the measure tool that you use. And then again, what are you really trying to measure and in whom, right? So you want to first sit down and really ask yourself these questions. So the next step, after you've asked yourself, what are you really trying to measure and why? The next step is to collect information on existing measures. So this is where the tool really starts to come into play. So you want to collect information on your existing measures, and I'll talk about some more ways to do this, but on the decision tool, you'll see talks about you can visit free or open source directories. You can look at something like Google Scholar, or your healthcare setting that you're working in might already have some type of repository for measures. So I've gone through some of these. I can't emphasize enough, Google Scholar is actually really helpful. So I have a lot of library resources. I have access to the VA library as well as the University at Buffalo's library. But I'll be honest, I often wind up using Google Scholar instead of those things. It's quick and it's easy, and everybody, assuming you have internet, has access to Google Scholar. So I recommend that as a potential place to look. Additionally, there are a lot of free and open source options for you to find, rather than having to go into Google Scholar and type in, looking for a brief measure for depression. Some people have already compiled big lists of these things for people in your position. Some of these are listed on the decision tool handout on the back. This is just the top page, the top portion of that. But I provided, I think, 6 online free open access databases that have a ton of different measurements. And I talked about on there what some of the things that are included on that database, some of the different types of measurements. So these are really great, and they're really expansive. So when you have some free time, I would highly recommend checking out some of these resources and just seeing really the really seeing the breadth of possible measures that are out there for your use. What's really great about some of these, when you do have the time to check them out, is right within the database or within this repository, they actually include some of the information about reliability and validity that I'm going to talk about next in the presentation. It's just included right there on the repository. So I know I kind of talked about this in the opposite order, but I might actually recommend, once you've decided what you're going to measure, I would visit some of these free databases, and I would also then go to visit, one of a Google Scholar or a library, because these have done a really great job of already compiling some really good measures. So I would check these out first, followed by, if I didn't come up successful, then look, on a library or online database. So again, we started with identifying, then we visited our open source repository for measures, and we've selected a few that might look like they're going to work for us. Then you want to ask, does the measure that you found or the measure that you're already using assess what you really want it to? So you ask, what am I assessing and why? So this is where the bottom of the decision tool comes into play. So we provided a blank table that the goal of using the decision tool is to go through the decision tool and essentially fill out this table. So you want to ask all of these questions of the different measures that you found. Let's say you've identified, 2 potential measures for your research evaluation or clinical goal. This tool is really designed to help you evaluate which one better is going to fit your setting. So the idea is that you use the flow chart part of the tool to help you fill in this table. And then when you look at the table, it should be, or it could be easier to make the decision as to which tool you're going to wind up using, or which measure, I'm sorry, you're going to wind up using. So that's what you do here. So in this first part, let's say you've identified your two measures, you found what each of them assesses. You would put those into the two boxes at the top here. So then, the flow chart would then suggest that if they don't measure what you really want to measure, then you go back a step, right, and find some additional measures to consider. But assuming it does measure what you're really trying to measure, the next step will be to identify if there's any reliability or validity statistics available on those measures you've identified in the existing literature. So as I mentioned a second ago, a lot of times on those free databases that I was showing and those repositories of measures, a lot of those will actually list out things like reliability and validity. So you can see it right there. If you don't see that information right away, a couple of tips would include, first of all, you can Google the name of the measure plus the word psychometric. So if you Google, for example, patient health questionnaire psychometric, then what's going to pop up are articles that have looked at the psychometric properties of the PHQ. So that's a quick trick. You could also see if you can track down the original article that was written about the measure, and you can do that in Google Scholar or in your library database. So you can try and find that information that way. So I'm going to talk through a little bit about reliability and validity and what those things are and what you should be looking for. Again, this is included on your decision tool handout. I also want to mention, sorry, I should have said this before I started talking about the decision tool, but this might seem like a cumbersome process and that it would take a really long time to find measures and evaluate them. And, I'm talking through each step, so it's probably sounding pretty drawn out and slowed down. But I will mention, I've gone through this several times now, and this actually doesn't take that long. I think I was able to evaluate 3 different measures in about 20 minutes using this tool. So once you get comfortable using a database, this is fairly easy. Okay, so some terms and definitions. First of all, you want to consider the reliability of the measures that you're considering using. So another term for reliability is consistency. So how consistently do the items on your measure the thing that they're purporting to measure? What's the consistency? And there's a few different kinds of consistency to consider. The first, and this is the one that I tend to look for and gravitate toward finding, is something called internal consistency. So what internal consistency is it's asking, are the different items on the measure consistent with each other? This is sometimes also called split half reliability, but more and more I'm seeing this called internal consistency. So basically, if you think of this another way, you can just think about, if your measurement has 20 items on it and they're all supposed to measure, let's say, depression, but 3 or 4 of them don't really seem to measure depression, then that measure would have lower internal consistency because those 4 items are not measuring the same thing as the overall measurement. And this is typically measured by something called Cronbach's alpha. So you can see some basic cutoffs listed there on the right for Cronbach's alpha. So you'll find this in the literature. What you're going to try and look for is a Cronbach's alpha level of about 0.7 or more. I'm sorry, I'm having a coughing attack here, so I'm going to put you on mute for 1 second. Okay, sorry about that. So you want to look for a Cronbach's alpha level of about 0.7 or more. The next concept that you might see related to reliability is around 2 different things, so test, retest, and inter-rater reliability. So what these types of reliability are measuring are basically, do patients answer consistently over time? And If two people looked at the results of your measurement, would they come to the same agreement? So do the raters agree? And this is typically measured using something called an intra-class correlation coefficient. One thing to keep in mind is you want to consider if you're expecting your measure to change over time. So if it's something that you're, applying an intervention to and expecting to change, test retest reliability may be somewhat less important for you to be paying attention to. Nonetheless, you want to pay attention to this, and there's some cutoffs listed here. So good intraclass correlation coefficients start at about 0.75 and go upward. So almost the same scale that you see with Chromevox Alpha, with just a couple of differences. So what I want to note about this is these are just cutoffs, and these cutoffs have been derived through looking at various validation statistics. But if you find a measure that you really like for a lot of other reasons, and it has, a 0.69 internal consistency rating, it could still work for your purposes. These are just cutoffs. So it depends on the purposes of what you're trying to do and what you're trying to ultimately do with your findings as to like how strictly you adhere to these guidelines. But in general, you want to try and find the best ratings you can. So if you have two measures that are otherwise equal, but one of them has really good internal consistency and the other one has, more questionable internal consistency, you would want to choose the one with a higher rating. So that was the quick crash course on reliability. So that's obviously important, but so is something called validity. So you've probably heard the term validity before, but in this situation, what validity is basically the extent to which your measure is correctly assessing the construct you're trying to. So if you imagine, there's basically two possible options. Let's say you're, an omnipotent being and you know the true state of affairs. And in the true state of affairs, it can either be the case that the person you're trying to measure is depressed or the person is not depressed. So that's truth, that's the reality of the situation. Then you have your measure, and your measure can produce two outcomes if the person's depressed or if the person is not depressed. So if the measure says that the person is depressed and the true state of affairs is that the person is depressed, then we have what's called a hit. So your measure is correctly identifying the true state of affairs. If your measure says the person is depressed, but the person is not depressed, then that's what we call a false positive. So our measure is incorrectly identifying someone with an issue that they don't actually have. On the other hand, your measure might say that the person is not depressed. If your measure says the person is not depressed, but the person is in reality depressed, that's called a false negative. And if the person is not depressed and the measure identifies them as not being depressed, that's called a valid negative. Now, you probably can tell pretty easily, the two things we're looking for when we consider validity are these. We want to maximize the number of hits and valid negatives that we're getting and minimize the number of false positives and false negatives. So we want to make sure our measure is catching the right people and not catching the wrong people. So some terms and definitions around that. Again, validity, does your tool measure what it's supposed to? And there's some different kinds of validity. The first one I'm going to talk about briefly is called convergent validity. So does your measure correlate with other measures of the construct? Okay, so does the PHQ-9 actually correlate with a diagnostic interview for depression? Because it should, right? If they're both measuring the same thing, they should correlate together. So what you can look for when you're evaluating this is significant Pearson's correlations, and these are often reported by the letter R. So you can look for a significant Pearson's correlation between two different measures. Some other terms, so sensitivity is the ability of your test to correctly detect the hits. So that first group of basically it finds the right people who actually have the issue are being identified with the measure. So this is, again, a cutoff score, but you want to look for a sensitivity rate of about 70% or more. So basically what that means is that your measure correctly finds about 70% or more of the people that it's supposed to. Specificity, on the other hand, is sort of the opposite of that, and it's the ability of your measure or your test to correctly detect the valid negatives. So it misses the right people. So it doesn't just, say that 100% of people have the concern you're trying to measure. It correctly discriminates between people who have the concern and don't have the concern. And again, you want to look for about a cutoff of 70%-ish or more. So basically that your measure is correctly identifying people who it's correctly detecting the valid negatives. So just to kind of recap some of that, what you see here are 3 different bullseyes. So on the left, it would be an example of a measure that's reliable but not valid. So all of the points on the bullseye are consistent, right? They're all seeming to be in the same area and kind of tightly grouped together. So they're all, if you were to use the metaphor, they're all measuring the same thing, but they're not hitting the target. They're not hitting the bullseye. So the measurement might be really reliable, but it's not actually measuring what you're trying to measure. In the middle, you see a test that might be valid, but not particularly reliable. So all of the dots are surrounding the bullseye. So they're all probably measuring something close to the bullseye, but they're not really within it. They're not reliable. They're not tightly measuring what you're trying to measure. And then on the right, you have something that's reliable and valid. So you see all of those little dots right in the middle. So it's both consistent with each other and measuring the same thing, but also valid. Okay. So again, the crash course in reliability and validity, I know those can be, sort of scary concepts or boring concepts even, but they're really important to this question of finding and evaluating good measures. You need to know about those things, and you need to be able to pick out some of those statistics in order to evaluate your measures. So on your decision tool, you would write down what some of those statistics are. So you'd write down, what the sensitivity is, the specificity, what the intra-class correlation is, all of those things, and see if they adhere to some of those cutoffs that I had suggested previously. So the next set of steps are also important, and these come next on your decision tool. So you want to then identify if your measure has been used or validated with the clinic, setting, patient type, etc., that you're planning to use it for. Now, this is where things can become a little bit trickier. Ideally, we would be able to find a measure that has been used in the exact clinic type with the exact patient population that we have, right? So if you're, for example, doing your measurement in primary care, but your measure has only been used before in a specialty care setting, then that might decrease the validity of using that tool in your setting. Because it hasn't been validated for use in that particular setting. However, if it's the only measure that's available for whatever it is you're trying to measure, it might be preferable still to using a fully homegrown measure. So this is an important question to consider, and you want to try and find things that have been validated in your exact setting, but that can become increasingly difficult as you have more and more specific questions, right? So you want to go for it as much as you can, and see what you can find. So this can also be related to things like type of patient. So if a measurement, for example, has only been used in children and adolescents, it might not make sense to choose that item or that measure then to use in adults because it hasn't yet been validated in adults. So you'd want to try as much as you can to find a measurement that has been used in the population you're trying to measure. These next set of questions are on your decision tool are related to issues around feasibility of using the measure. So how many questions does the measure involve? How long does it take to score? So you know your setting that you're using the measure within. You know how much time approximately patients will have to complete it or providers will have to complete it. You know how much time you have to administer and score it. And to, some measures require instructions. So you'll know, you can figure out if you will have the time to provide all those instructions. But these are questions around how feasible is it for you in your setting to actually do this measure. So a lot of times, in the integrated care and collaborative care world that I think many of us are in, we'll find measures that were grown out of specialty care settings that, on the surface look great. They have great reliability. They have awesome validity, but they're 400 questions long and they take an hour and a half to administer. Clearly, that's not going to work for most of us, right? So you want to obviously pay attention to these issues as you're looking for the measures you want to use. And I want to caution people here too. It can be tempting when you find a really good measure, but it's too long or too cumbersome, or some of the questions don't apply. It can be really tempting to just cut out questions and chop those off, or only use the questions that apply to your exact question. But I want to caution people against doing that, because as it turns out, when you change a measure in some significant way, like removing items or changing the instructions or things like that, it can actually lower your reliability and validity. So rather than that, I would recommend trying to find a shortened version of that measure. So a lot of times, if you find a long measurement out in the world, if you type in or if you put into Google the name of that measure and brief form or short form, something like that, a lot of times those shortened versions have been created already for this exact reason. So I would recommend trying to find a measure that has been validated at the length that it's at. And then as a final point, or not as a final point, but as an additional point around feasibility, you want to make sure that you're not breaking copyright laws when you're using measures. So you want to make sure that the measure is open source, if it's free, or if it's copyrighted and comes with a usage fee. And this is typically printed right on the measure itself, or a lot of times measures will have like a cover page and they'll talk about if it's copyrighted or who you need to contact to use it and things like that. This isn't necessarily a rule out, right? If you found a measure you really want to use, but your institution has the resources to purchase that, that could be just fine, but you might be in a position where that's not possible. Something that I also want to note is a lot of times measures are free to use in clinical practice, even if you would have had to pay a copyright fee to use it in research. So there's usually language written on the measure around that, so that it's basically, free to use with a patient. If you're planning to use any of the data for research purposes, then you would have to pay the copyright fee. So you just want to make sure you're paying attention to that issue. A lot of people will use measures that are copyrighted, that they should have gotten, that they should have paid a fee for, and they're using them inappropriately, and that can lead to some legal trouble down the road. So I want to advise everyone just to pay attention to that. As a kind of side point there, just another tip, a lot of times the developers of the measure will allow clinicians and others to use the measure, or they just want to know who all is using it. So sometimes if you just send a quick email to the developers, they will grant you permission to use it in your setting. So that's these boxes down at the bottom of your decision tool handout. So the idea again is you're filling out all this information for all of the potential measures that you found and you want to use. So you can quickly kind of look at this table then and see what the measure that kind of rises to the top in terms of the best ratings would be. So that's these final pieces here. So keeping a few things in mind. So I've already talked through some of these things, but I want to give just a little bit more detail on a few points here. So has the tool been validated in your population? And this is particularly important if you're trying to publish the results of your measurement or your research. Again, if you're using the measure in a population that was not originally intended for, you might run into some issues down the road with trying to get that work published. And again, exercising caution when using adult measures with children. I did want to talk a little bit about language, because that's a common issue with finding and using validated measurement. There might be a validated measurement that exists in English, for example, but not in the language that you need it to be in. And it's typically much easier to find English language measurements. However, there are sometimes foreign language translations that have been validated before. So two kind of tips for translating or finding translations for validated measurements. The first is let's say you found a measurement, it's in English, and you need it to mean another language, try and contact the author of the measure. A lot of times they'll know if someone has validated a different language of their assessment tool, or they'll be aware if there's work in progress for that. So reach out to them directly. In terms of, you personally translating the measurement, this isn't the ideal situation, but if it's, and in doing so, you might wind up losing a little bit of validity and reliability. But if it's something that you have to do, translating it first into the language and then back into English is kind of the best way to ensure that you're not missing any of the information from the original measurement. But do keep that in mind when you do things like that. So when you change the measurement in any way, by doing something like translating or changing items, you do then start to decrease validity and reliability. So that's sort of the cost one might have to pay in this situation. So again, I already talked a little bit about this, but has your measure been used in a particular clinic or in a particular population? You want to try and find measures that have as much as possible. As kind of a note on that, so if you can't find a measure that has been used in a particular, in your particular population, and you wind up using one that has not been validated in your population, you could consider, writing up a little paper on that, or partnering with someone in research to help you publish that, so that then you could show that it could be validated in your population. So I guess that's just kind of my plug. If you're using any of these tools in a way that's new or different, you might consider partnering with, or if you yourself are a researcher, you might consider actually trying to figure out some of these answers around reliability and validity. And then again, you want to consider, if your measure, you want to consider the concept of sensitivity to change when you're selecting your measure. So if you're trying to show change over time, right? So, an improvement in a particular symptom or in functioning, or anything like that based on an intervention that you're providing, you want to make sure that the measure that you're selecting is sensitive to change and isn't measuring something that is pretty, static. So sometimes people will select measures when they're trying to measure something like mood or depression. They'll accidentally select something about like trait level negative affect, which is not something that is known to change. That's just one quick example. You want to make sure that the construct you're trying to measure and the measure you're using is sensitive to change. And the best way to do this is to see if any of the research studies that have ever used the measure have found any change on that measure. So you could just pop into Google Scholar, PHQ-9 change over time, and you'll find all kinds of stuff showing that, as a result of different interventions, scores in the PHQ can change. So you want to keep that in mind if change is something that you're trying to demonstrate. And finally, of course, you want to consider the clinical utility of the measure that you're using. So if, the change over time that your measure is able to detect happens, but maybe it's not really that clinically meaningful to you. Like maybe it doesn't really matter if someone has a 2-point change on a measure. Maybe you're looking for more dramatic sensitivity to change. So you want to see bigger levels of change. You just want to consider the clinical utility of the measurement that you're using for your particular setting. And this is particularly for people who, I think probably much of the audience are people who have a foot in a clinical door, either as a clinician or as a clinical evaluator of some type. So I think it's important to consider the clinical utility of any measurement that we're choosing. So the final point that I'll kind of go with here is you want to make sure when you're implementing a measure to assess something that you know how to use it and you know how to teach staff how to use it, and that you're making sure that they know how to administer it properly. Because if the way that you're administering the measure is no good, then the results that you're going to get from the measure are also going to be no good. So an example of this is within the VA, we have annual screenings for hazardous alcohol use by asking questions from the audit. So just asking some general questions around drinking behavior, frequency, and amount. And it has a very standardized way that you're supposed to ask the questions. what I hear clinically sometimes as I'm, walking through my clinic, I might hear someone administering this measure, and rather than administering it the way it's supposed to be measured, they're saying things like, oh, you're not drinking at all, right? And so you could probably see the problem with that. So rather than asking the questionnaire in the way it's supposed to be asked, they're asking it in a way that's probably going to lead the patient to answer in a less than valid and less than reliable way. So that's something to keep in mind with any verbal measurement that's going on, as well as if any of the measurement that you're providing has any instructions to the top of it or administration instructions for you. These are things you want to keep in mind, is that you and your staff know how to correctly administer the measure that you're using. Okay, so there's just a couple of my references there. And I see that I've ended about 15 minutes early here. So if there's any questions, I'd be glad to take them.
Great, thank you so much, Julie. Yes, so again, you can use either the Q&A or the chat function if you have any questions for Dr. Guess.
All right, I guess I explained reliability and validity perfectly then.
I think so. Well, thank you so much again, and I hope everyone has a great rest of their day.
Yep, thanks guys for listening. And again, if you need that decision tool sent to you again, just let me know. I will get that out, and everyone have a great holiday season.
You as well. And this webinar recording will be posted on our website. And